meeting is now being recorded.
So good afternoon or good morning, depending if you're on the West Coast, and thank you for joining us today for our Quality Forum for investigating social media data as an adverse drug event surveillance tool. My name is Matthew Pickering, and I serve as PQA's Director of Research and Quality Strategies, and it's my pleasure to be the moderator for today's presentation. Before we begin, I would like to call to your attention a few housekeeping items. First, all attendee lines have been muted. You are encouraged to ask questions during the presentation using the Q&A feature located at the top right of your screen. At the conclusion of Kyle's presentation, I will read the questions for him to answer. Additionally, this Quality Forum is being recorded. The recording will be posted on PQA member-only portal next week. So it's my pleasure to introduce our speaker for today. Dr. Kyle Holtgren is the director of the Purdue University College of Pharmacy's Center for Medication Safety Advancement, or CMSA, and holds a courtesy appointment as Clinical Assistant Professor of Pharmacy Practice. In his role at CMSA, he leads a team that pursues the development of innovative safe medication use practices, as well as engaging methods to educate healthcare practitioners and student pharmacists. His current work includes predictive analytics for adverse drug events and utilizing simulation methodologies for training medical professionals on safe medication use practices. With that, I'd like to turn it over to Dr. Holtgren. Take it away.
Thank you very much, Matt. Looking forward to being here, and I hope everyone, thank you for sharing just a part of your Thursday afternoon with us, and hopefully you'll be able to take something away from this, and if nothing else, a really good discussion. And I did want to start with that, certainly by thanking PQA for the opportunity to speak, but also just as we jump into the presentation here, to mention that this is really some very early stage. I've had a good opportunity to listen in on some quality forums before, heard some wonderful speakers talk about very actionable things that they're working on. This will be a bit of a different take on some of that, so hopefully you'll be able to appreciate that and be able to offer some good feedback. This is some very early stage research and some things that our team has been working on here at Purdue, some things that we're very excited about. And so with that, hopefully you'll be able to offer some great feedback, ideas, criticisms, some things we can talk about in the Q&A at the end. And I would really love to hear your feedback on this, because that really is going to help shape the direction of where do we take this. Is this something that merits further or deeper investigation? So I just wanted to set the table with that, because this may be just a bit of a non-traditional approach to these quality forums. Having said that, we'll start out. What are we going to talk about? We'll start just starting over and talking about the components of an adverse event, talking about some of the definitions and some of those pieces as well. Understanding the importance of the FDA Adverse Event Reporting System, or FAERS. We'll describe who uses FAERS, whether it's mandatory or voluntary reports, some of the components of where did the data come from and what does it make up. And then we're going to talk a little bit more about what the title would suggest. We'll spend a lot more time talking about our Twitter Adverse Effects project and how we've been starting to use social media data as a bit of a surveillance tool for adverse drug events, trying to find out if there is any correlation to some of the known quantities such as FAERS. So start by getting on the same page here. This, for everyone that's involved in PQA, certainly you're very used to the idea of standard definitions. You know, before we can design a measure, we have to come to a consensus as what is it that we are measuring. Now, certainly medication error is a little bit different than defining hypoglycemia or a serum glucose less than 60, 55, whatever you would choose. We have to find a little bit more of a broad sense. We talk about medication errors or adverse drug events, adverse drug reactions. So this one comes from the National Coordinating Council for Medication Error Reporting and Prevention, or NCMERP for short. And I won't read the whole thing out loud to you. It's quite lengthy. But just notice that there's a lot of commas and a lot of locations at the bottom. Really, we're just talking about preventable events that may either they're causal or will lead to inappropriate use or potentially harm. Now, not necessarily harm. And you'll see down at the bottom, it can happen anywhere from manufacturing, labeling, repackaging, administration, dispensing, monitoring. All of these are opportunities whereby we can find that there are opportunities for error can get introduced. You know, medications can certainly be dispensed and to patients the correct medication, right patient, right drug, right time, but there are still so many more opportunities for adverse events to kind of slip in and harm patients as well. And so this is just kind of making sure that we're all on the same page. So how do we report errors? What are some of the things we have to do? At its absolute core, this is what it is. So what are there's 4 really core requirements that the FDA requires for an event to be reported. Those 4 key components are, first, an identifiable patient. There has to be someone that this happened to. Second, an identifiable reporter. Someone has to be actually making the report. Now, certainly the first 2 may seem a little bit common sense, but this also actually helps provide as a fairly useful filter. Excuse me. This helps to filter out things that would be, everything that was hearsay or just more of a public record. This is more of an individual making a report about themselves or another individual. And the next 2, there has to be a suspected drug or biologic product. This can't just be, well, I took my medication and it upset my stomach. That would be an incomplete report. Only 3 of the 4 were present. We need to know the name of the medication that you took. So that's suspected drug. And then the 4th one, there has to be an actual identifiable adverse event thought to be due to the suspected drug or biologic. Now, this does not have to be proven or established causality. This can simply be something as basic as your aunt, your cousin, your friend, your mother and father, someone calling you and saying, I was taking my statin, I'm being non-specific, but rather I was taking my atorvastatin and it really upsets my stomach. All 4 core components are there, and this would be an error report. Now, that may not be formal MEDRA dictionary definitions or generic names of meds, but all 4 core components are there and would qualify. Now, there are pros and cons to this. The benefits of using just these 4 certainly is it keeps it broad. This encourages a when in doubt attitude. The idea that when in doubt, as long as you've got these 4 things, report it. We want to hear about it. Tell us what's going on. We want to make the hurdle as low as possible to clear to be able to report information. It can be very intimidating if the minimum threshold to report is 71 fields with numerical quantities, locations, times. You're going to really thin out what you're going to receive. Now, you may get higher quality, but with much lower quantity, it may be difficult to parse out what's happening in the system. Now, the drawback to this certainly is that we may get a lot higher quantity, but maybe lower quality. You may get a higher rate of false positives or a higher rate of things that are just non-actionable. Things whereby you get a series of 100 reports of self-reporting of my generic medication is giving me a headache. Well, is it? Are you on 15 other medications? Are you eating? Are you not eating? Or there may be a lot of things in here that prevent us from establishing causality. So this is important, again, for those core reasons. There are pros and cons, and we'll go through and we'll talk about this again because this will come up very acutely when we talk about social media data as well. So let's jump in now to where do we aggregate this information. So let's talk about the FDA Adverse Event Reporting System, or FAERS for short. So what is FAERS? FAERS is a large database launched in fall of 2012 by the FDA. It contains the adverse event reports, medication error reports, quality complaints, manufacturer reports, healthcare provider, lay public, all of these reports that were submitted to the FDA. There are some limited reports earlier on because they would have had to be manually entered, but from 2012 on, everything done digitally or online has been placed into the database directly, and so all the data fields are there as they were reported. This has been helpful. The FDA has been citing that they've been seeing certainly an uptick in some of these adverse event reports and also an uptick in the number of people exporting this data and using it for many of these purposes. So what is this comprised of? 2 main categories. Many folks may be saying, well, what about this Medwatch thing I hear about? What is that? Well, FAERS is the large database. Medwatch did not go away. Medwatch, if you were to log on to FDA.gov and click on the button, of which hopefully if anyone here has experienced or observed a medication error or an adverse event, I would encourage you, please do this as a practitioner or even just as a patient or a person taking prescription medication. Use this service. It really is very easy, intuitive, and very helpful as well. But Medwatch is that portal where consumers and healthcare professionals can digitally online go to the FDA and report these adverse events, these medication errors, things that are happening to either the patients they're serving or to themselves. FAERS also pulls in another bucket of information, the mandatory reports that are submitted by manufacturers. So if you're familiar, certainly there are in terms of clinical trials, phase 4 is the post-marketing surveillance phase. And so manufacturers are required to to surveil medications they have that are being marketed to identify, are there any adverse events happening to people, and report these to FDA on a routine basis. And so these are submitted certainly either in expedited if it's more acute and we need to get the information out, or on more regularly non-expedited reports. FAERS aggregates both of these buckets, those voluntary error reports as well as the mandatory error reports from manufacturers, and compiles them into one large database that is this FAERS. Now, this is pretty neat because the FAERS database is quite large. There are over 10, I believe it's almost 12 million individual entries now at this point. So, but with this, there's certainly, maybe you get a theme here that, or maybe it's an academia thing, but the notion of addressing everything not as a universal concept, but there are pros and cons to everything we do. You know, we certainly make trade-offs, we make choices. This is a choice we've made of how to report errors and categorize them and use them. And so certainly there are limitations, certainly. We still experience an underreporting of adverse events. By some estimations, a fairly egregious underestimation or underreporting of adverse events. There's a perception that older agents, or that if you get an upset stomach on cephalexin or cephalosporins or penicillins, that's just an expected adverse drug reaction and there's nothing to talk about there. Or if it's on the package insert, then you shouldn't report it. There's just a general sense that maybe some of the older agents, we just don't talk about these things. There's a lack of willingness sometimes to report things by healthcare practitioners and certainly by consumers as well. The FDA does not require that a causal relationship between a product and an event is proven. I, for one, would think that this is a good thing. If we require causality, I think we would see a precipitous drop-off because, again, if the barrier to reporting many times is cited as the amount of time it takes, if you also have to be able to demonstrably prove causality in your error report, you're going to spend a lot more time in there. And again, I think you're going to find no guarantee that it's accurate, but fewer reports getting submitted. But again, it is a limitation. We don't often have that. We just have the reports, and we have to look at this as almost population health level data. We cannot necessarily draw conclusions, but we can draw or try and identify correlations or fields of interest for more deeper research. FDA does not receive reports for every adverse event recorders. Certainly not. This again goes number one, underreporting. The only mandatory reporting is the surveillance for manufacturers. It is not implicit, it is not required of consumers. If you or I are taking our medication and it harms us, something happens, we are not required to report that. Duplicate reports can occur, certainly. If the individual is every single time, and maybe we all know someone like this, if every time you take your medication it gives you heartburn and you take one tablet a day, at the end of the month you would have submitted 30 adverse event reports for heartburn on this medication. And maybe some of you are clinicians or practitioners and you know exactly the type of patient I'm speaking of. These are the individuals that are incredibly helpful, but again, we can get duplicate reports like this. Reports don't always have sufficient details to investigate. So even if we get a relatively good report that we feel may help us identify some causality, the reality is at the end, there's not enough information here to go back. We're not requiring patients' names, phone numbers, contact information. It just needs to be an identifiable person. It doesn't even have to necessarily be identifiable by name, medical record number, IP address, anything like that. So we don't always have those details. Now, I put this slide up here. It seems like there's a lot, but I think this is just more in fairness to address the reality of this, that when we start talking about large data sets like this and compiling them, we're not going to have a uniformity of data. There's going to be quite a wide swath of how data comes into us utilizing this particular methodology. So this is what it looks like. This is what happened. FDA took all of the FAERS data a number of years back, and they put it on something called open.fda.gov. This is something that anyone can go to. OpenFDA is the publicly accessible database, and it's also downloadable. And this is what you see here on this slide, though, is the user interface. This is where you can go and run some fairly basic queries on type of adverse event. You can search by drug name, adverse event type, and it'll show you some basic graphs, some tables, and you can see some information here just like this. Now, some of this information here, you'll see some of these total reports. Up there you see 14.8 million. So I was close with 12. Certainly it's been updated more recently. But again, you'll see these numbers kind of coming in, and this certainly is a friendly enough, but if you do spend any time with this, you'll notice that it can be challenging. The queries are not always incredibly powerful. Sometimes you're not able to get everything that you'd like, and sometimes the actual displays are not giving you the exact information you like. You would want the raw data, the raw information. What is actually populating this? So that's one of the things that Purdue set out to work on. And we took this to the next step and created our SafeRX database. This is what we used as the basis for our comparison for our social media work that we're doing as well. So what does this look like, and why do we use this? So SafeRX is a project collaboration between CMSA and our Rosen Center for Advanced Computing here at the university. And what we did was we took all of the FAERS data from FDA as well as the full registry of NDC codes to be able to create a categorization for ourselves, to find out how do we identify and put drugs into categories. We're still working on getting a meta dictionary loaded, but the nice thing is that this is a customizable database. SafeRX is wonderful for us because we get the raw data on all the adverse events from FAERS, and we can lay that on top of MEDRA, on top of NDC codes, and shortly you'll see our aspirations, we can lay that on top of Twitter. So now, rather than just being a searchable, queryable database of adverse events reported to FDA, now we have a large aggregation of raw data that is comparable. We can search this, we can compare, trend over time, and against other user-imported data sets as well. Some of these may be large national data sets, such as the NDC or Twitter. Some of these may be independent or homegrown data sets of your own, from your own individual source. Maybe you're from a health plan or a provider, a health system. You can overlay individual sets. And so we're working on building this capability in as well. And it's really helped us get a much better kind of zoom from the population level into the more acute level, really close to where we're at. So just a brief tour to show what is it that we're working with when we say the SafeRX, and how are we able to use this in a little bit more of a powerful way. So this is just kind of a screen capture of some of the things that we do. Rather than using some of the individual codified categories provided on the OpenFDA, we try to create date ranges, things that were much more user-friendly in terms of genders, age, not specified, unknown, countries. Now, just because this is the FAERS database, there's surveillance data from well over 150 countries around the world. And so now some countries may have only 15, 20, 30 adverse event reports in there for a given year. Many others have tens, if not hundreds of thousands. And so this is really, in many ways, can be a global way to kind of search for these. And so we've used this, and we've really enjoyed kind of digging into this, and this helps us zoom in specifically on one outcome type, one medication, one adverse event, or one particular population, or one time frame. We're also able to identify or select and populate different reports as well. We're able to find out what is it that we're working on. Do we want to look at top drugs for reactions? Do we want to look at individual medications? A case summary report. Many times with the raw data, this is powerful. We can go back and look at concomitant medications. So perhaps there was an adverse event reported because a patient was on insulin. Well, what other medications were they on? Were there maybe some precipitating factors? Were there things going on here? And so we're able to kind of dig in and find out what was going on. So now that we've got that, I really do want to spend the rest of the time digging in, finding out, and talking about our aspirations and how it is that we use this for looking at social media data as an adverse drug event screening or surveillance tool. So let's start back at the very beginning here. And let's look at the individual components of a adverse event report. As you recall, there's those four key areas. The first one, an identifiable patient. Well, right here you'll notice this is just even in the last week a tweet, singular from Twitter, if you will, a single tweet pulled down off of the website Twitter using the search. We've blacked out some identifiable names here. Certainly not required. Twitter is a publicly accessible information, so all these sources are published and they're perfectly viewable for anyone. But you'll notice there's an individual name there and an identifiable patient. That's the person. Identifiable reporter. This person is talking about herself. Number 3, anybody ever come off long-term Adderall use? We have the name of a suspected medication. Again, it's suspected medication. We want to make sure that this individual is not misidentifying or using a generic term for any other particular medication that this patient may be on for a prescribed or her diagnosed condition. And then you'll notice me here, and it says, about coming off, but I hate life when I quit, even after weeks off. Now, this is a suspected ADE. You'll notice that, and again, not trying to be overly silly or facetious, but the lay public does not typically codify tweets using the Medra dictionary. And this is certainly to be expected. And so one of the challenges certainly is identifying what do we mean by I hate life. Is this a nausea, a discomfort? Is this something that would be an adverse drug reaction associated with tapering off of medication use? And so, but we still have inside of this those 4 core components of an adverse drug event. And so this is something that was really very interesting, really in just the last 5 or 6 years. A lot of folks have started to recognize and realize, well, gosh, is this really being aggregated anywhere? Are we talking about this? The sheer volume of Twitter alone, millions upon millions upon millions of tweets per day of people talking about any manner of things, sports scores, kids' swim practice, and medication use. All of these things are out there for viewing. And so the question is, are we getting good data? Does this exist? And so we recognize here that, sure enough, we have these 4 core components for an adverse drug event. So now, not all reports and not all tweets, not all social media is created equal. So we have to ask ourselves certainly a lot of really good questions. What percentage of these reports are actually significant versus an improper assignment of an event? We certainly have the lay public, we have patients, people identifying or correlating use of a medication or lack thereof with a certain effect. Are they correlating appropriately? Is it inappropriate use? Are they inappropriately using medications? Are they taking medications that were not prescribed to them? There's a lot of things that we need to be concerned about. And so, certainly there's many, many tweets in the social media out in nature that are that are maybe improper in nature, but this is not necessarily a bad thing. So if you find there are tweets out there about people intentionally abusing medications, perhaps even we talk about abuse of opioids. It's certainly something we can't seem to avoid from making front page news these days. That's not necessarily an inappropriate tweet. It's something that we may be able to capture and categorize and identify. This may be a much more popular venue even for people to take to discuss the abuse of medications than a formal setting. We think about healthcare practitioners making a formalized report about abuse of medications. How many people abuse medications that don't end up in emergency departments or acute care facilities on a daily basis? But how many of those take to social media to identify locations or where it is they can obtain these medications? And so these are all, again, not answers. I certainly don't profess to know the exact answer. These are just the series of questions that we've been able to continually address and identify that may be very helpful for us to keep talking about. So again, how do we design the algorithm to address this? How are we able to parse through and sort them out? I just mentioned there are millions and millions of tweets. It's something whereby it really is the fire hose. It's a torrent of information. If you're able to even put it on a screen and see every single tweet come in live, it would move too fast for your eyes to read. That's certainly how rapid this information comes in. And the final question also is, in terms of not all reports created equal, why did we start with Twitter and nothing else? Well, Twitter is also basic because it's based upon the basic premise. When we started, on 140 characters comprises a tweet. And these are just alphanumeric characters, and makes it easier for us to go through. And there's also a central repository of that information. When you think about blog posts or other image sharing or Facebook, you have to use a little bit more sophisticated technology or screen scrapes. There's more boxes and blocks and things that you need to be able to negotiate to find out what people are talking about. Twitter was a lot easier because it comes in unique parcel sizes of 140, or now I suppose it's 280 characters. And so it made it much easier for us to address. Again, this was really more of a limitation of the early stage research. It was easier to look at. We would certainly love to dig deeper into other social media in the future. This is just our rationale for why we started where we did. So now, as to this, what is the FDA stance, or regulatory versus manufacturing? I shouldn't say versus, but really in conjunction with manufacturing. How do we look at this? So I mentioned earlier there's phase 4 surveillance. So if I'm the manufacturer of a new medication and someone calls me, or a healthcare practitioner or a patient identifies and makes themselves known to me actively saying they were hurt by my medication, I am compelled and required to report that to the FDA. Now, if that patient is hurt by my medication and they take to Twitter and they discuss my medication and how they were harmed by it, I am not currently required to actively surveil all channels of social media or chat rooms or blogs or fax lines or any of these things to look for that information. And so there really is not a guidance on this notion of how do we report ADEs based upon internet posts or social media. Now, there's a slight difference here. If someone were to log on to, if I'm the manufacturer, and they went on to my social media page and said, your drug X caused Y harm to me, I must report that because, again, whatever communication vehicle they're doing, they're making a direct attempt to clearly communicate that to me as the manufacturer. When they're not making that clear-cut direction, again, now we start to enter a little bit more of this foggy area. So manufacturers not required to actively comb through these social media outlets. So, but certainly FDA and certainly manufacturers and academicians are starting to really get some more preliminary studies on the potential uses of social media as well. How can we do this? So, really, why investigate this at all? So there's a couple of opportunities as to why we should do this. Definitely, identifying unknown adverse drug events. The whole notion of the population health, when we've got maybe the idea or the will or the effect on 10 million people is something that is a little bit more understandable than the impact of 100 very heavily studied folks. You know, we're not we're all quite used to the notion of asking how many patients was this studied in. Not a lot of medications would get approved on a sample size of 4 patients. We want to see 400, 4,000, 40,000. We want to see large sample sizes to be able to demonstrate effectiveness across large populations. In that same sense, we may be able to identify unknown adverse events, things that happen over time or only those 1 in 10 million style events that may not come or float to the top otherwise. Accurate incidence rate. Again, right now, there are estimates that medication errors and adverse events are only roughly 10% of them are reported. Now, I know, again, that may get a bit of a chuckle on folks who are keen measure developers that how do we get 10% without a denominator? Well, certainly this comes from a study, and it's a bit challenging, but the notion of the real harm observed versus the amount of harm cataloged and documented has been noted in many studies over the years. And so, again, that's just an estimation. The real shock value is that it is a low number. Even if it was double or triple that, we're still talking well less than half. And so we have a very low accurate incidence rate of how many people are doing this. So if we have a new vehicle, a new form, social media, something people can take to from their pocket, something that can be very quick with only 4 required fields, maybe we're going to get a higher incidence rate. We're going to see more and more people reporting. Maybe we'll discover trends, previously unknown benefits as well. This may not be just people identifying the shortcomings. This may be people talking about all of the wonderful things. I never knew I could feel great or go this many days without a migraine, or there's a lot of things people take to social media and profess very positive outcomes about medication use as well. And again, as I am led to do, I give you the positive, and I want to discuss some of the shortcomings as well always. Certainly challenges the subjective nature of social media, certainly. Twitter certainly is not notorious for a scientific discourse. We do not often find academicians trying to prove theorems in 140 characters at a time. So there's a very subjective nature on social media posts. This is things that you're feeling or thinking or emotional reactions to things that are happening. And so there's certainly a very subjective nature. But that doesn't make it wrong or false. We have very accurate emotions and feelings many times. We have very accurate gut feelings. And these are things that can and should be captured. So, again, that subjective nature means that it's difficult for that causality, but it's not a reason to not capture them. And we've talked ad nauseum about this idea of causality and identifying meaningful information as well. So, zooming in now specifically to our work, what have we looked at and what have we done and what do we want to do with it? So, first, looking at this one, this is an early study from back in 2014 done in conjunction with the FDA. And this one is just really taking a first blush at a little over 4,000 tweets trying to talk about, again, not causality, just looking at, is there a correlation between social media and FAERS data or any kind of known rates? This really is why I started this particular webinar talking about some of that FAERS data, because it really is some of the best source, even if it is, again, we have some challenges with the completeness or some of the various aspects of it. It's one of the better databases that we have access to. And it also right now gives us the idea of overall rates or just raw numbers. How many people are reporting adverse effect X on drug Y? And so we want to compare Twitter to that. We want to find out, okay, so if people are complaining about nausea with taking drug X, how many times are people doing that? We find that roughly 1,000 people a month report nausea on FAERS, and that's maybe 10% of the volume of adverse event reports. We take to Twitter, do we find a similar rate of reports? Are people actually reporting roughly 10% of the time? Are they talking about nausea with this medication? And so this initial study in 2014 went to really kind of peel back and ask that question. I would say that the real question here is basically, is it valid? Should we be talking about social media at all? And I think it's also neat is that this is one of the studies, and there's another one I'll show you in a second, that begins to almost flip the question around as well, is that, I think it's also fair to ask, is the FAERS data as well? It's certainly valid because we're reporting it, but is that 10% number in FAERS valid? Because what if we find that the prevalence of nausea on drug X is significantly underreported and it is rampant when we look in social media or support groups or blogs or Facebook? Or is it dramatically underreported? Do we have an exaggeration of it in FAERS? And so we just want to do this kind of this cross-correlation, trying to find out, are we able to support? We're certainly not trying to replace one or the other, but are they able to support each other and validate each other as well? This study as well, this is a little more recent, this is 2016. This is a bit more of a qualitative description as well. This one talks a little bit more about just talking about percentages, types of errors. They looked at a little over 1,000 tweets and found out what type of error. Were these procedural, medication, diagnostic, surgical, emotional response, adverse events, and people were discussing these. And so they went through trying to find out, really, the question is, can we use it? And it gets more to a language question. And so we talked earlier, and again, I intentionally chose the tweets that I did when people will use phrases such as like, it's killing me, or I really feel like this is hurting, or does hurting mean actual pain, or is hurting meaning nausea or headache or GI distress? And so we want to look at more of that language. Can we actually go through this subjective social media database, go through and almost codify a common language to find out what are some of the colloquialisms, and can those accurately be categorized into a useful set or a dictionary term for us to use for ADE surveillance? So looking at some of the background, again, there's not a tremendous deal of background, so we decided we wanted to go through and create also a small database, a repository, similar to what, again, FDA and the preceding two studies had done, and find out, are we able to first replicate? Many studies now, the question becomes one of replication. Are we able to take the methodology and get the same results? So we were certainly interested in that, in using our SafeRX database. And so we've gone through, and we've used it in individual parcels, 300 tweets from an uninterrupted time period that mentioned one specific drug, and determine what percentage of those tweets contain adverse drug events. Again, our overall purpose is we want to compare that data set to FAERS data and try and find out, are we able to compare the adverse events and the percentage and quantities that we find in FAERS with what we see reported through Twitter as a social media modality. And then finally, we want to compare those two and see what happens. To date, we've done this now on over 40 drugs. We've been able to go through and continue to add all of these together, and I certainly, this is not an individual effort. I know that there may be some folks looking at this right now saying, my goodness, how did you do that? 2 words is brute force. It's unfortunately right now that's what we've been using, and it's been with some significant help. And so there's a number of people I just need to acknowledge at the end. I'll just say that right now as well. But so this is just an example of one of the things we talk about. And so this is Cymbalta, and so we utilize, and here you'll notice, I do want to disclose, certainly this is a trade name. I'm not making any statements about my belief or support in, for, or against any particular trade or generic medication. But what we find is that when we conduct searches on Twitter, many times using the trade name will get us a bit more robust results. So we can certainly add an algorithm to look for both trade and generic, and we found that using trade names tends to yield us better results. And so we use this right here, and certainly I cite it as such because this is one that we definitely have done. So I just want to make sure that I put that caveat out there fairly clearly. But one of the things that you'll see is we were able to get a pretty good overlay here. There were certain things here that we found that were definitely stuck out on Twitter, and some things that definitely stuck out on FAERS. But overall, only the top 3 FAERS ADEs were not reported on Twitter in the span of 300 tweets. This was very interesting to us. Twitter had 20 types of ADEs more frequently than FAERS. It indicates that some ADEs may be more reported often on Twitter. These may be ADEs that are not considered significant enough by consumers to visit a healthcare practitioner, perhaps. Certainly a limitation, several Twitter reactions were difficult to classify based on subjective nature. This is a very diplomatic and politically correct way to say if you spend any amount of time looking at social media data, you will have to adopt a certain sense of humor about how people describe adverse events about the medications they're on, specifically any GI medications or well, I'll let you use your imagination on any things that are going on, but it certainly is something that, while humorous at face value sometimes, it is a difficulty to classify based upon the subjective nature on how people describe the adverse events, and they can be classified differently. Again, here, I definitely want to acknowledge Dr. Rachel Wilson, now Herdigan, who put this particular study together. It was incredibly helpful. So what do we do with this? What are our opportunities for expansion? We want to certainly continue to demonstrate that we're able to find that, yes, we're starting to work towards establishing a correlation between social media data for adverse drug events, that it potentially is a valid place to look. We're starting to see that it can and many times does line up with established reporting rates identified in FAERS, but they can tend to complement each other. These things may work well together. One may provide a little bit more of a rich profile in certain areas than the other, but there's certainly an opportunity here. So where do we go with this? We definitely want to expand. There's opportunities here. As I mentioned, the SafeRX database. We'd love to add and automate our Twitter process. We would like to add Facebook, message boards, online communities. Online communities are absolutely wonderful. Finding support groups, people that join groups for chronic conditions have certainly a level of candor in many of their support groups or chat rooms that is certainly many times can be heartwarming or heart-wrenching, but also a place where we get really good information about what is it that really is causing discomfort to people when they're managing chronic illness. And so this is something that it can be something we can look at as well to be able to hopefully help prevent some of those harms. One other note on that I mentioned, and on all these modalities, getting to some of the questions folks may be asking, is that there really is a candor that I will admit I was not prepared to see. I was certainly initially a significant skeptic. I almost had to be talked into this by a number of graduate students and peers because I thought that there would be a level of either reserve or the notion that people don't want to discuss certain things. But the level of candor in what people want to discuss, the accuracy on how they describe adverse events, oftentimes leaves nothing to the imagination. And again, this is not being humorous at all, but people really, if they are in a spot that is making them uncomfortable or experiencing discomfort, are very specific, so they might find someone that's either experiencing that or can calm or assuage them, saying, hey, this is normal, or no, that's not, go talk to your doctor. And you see many conversations take place in this on Twitter. And so the level of candor really is something that surprised me. You see some, again, we can only assume to be fairly profound levels of honesty in some of these social media posts. So now the problem going forward, how does Purdue take this and how do we work with this in going forward? So certainly it's never going to be perfect. With any form of existing surveillance or any form that I have ever seen proposed, we'll never get to 100%. We will always miss something. And so we need to find out what are the best ways we can, and just because perfection is unattainable doesn't mean we're not permitted to pursue anything else. We have to reach for that goal. If we reach anything less and we achieve it, then we haven't set our sights high enough. So we have to design a better way to collect. There are a lot of opportunities here for us to look into feeds. There's services, there are companies that will, if you provide the algorithm to them, go through and they can parse in real time every tweet ever sent out, and they can deposit into a database for you every day or even every hour if you'd like, every tweet based upon your algorithm. If you say, search for the following drugs, and you provide a codified list of drugs, and you say, correlate that with, now that's a filter. Everyone that comes up there filters out. Next, everyone on that list that has a drug name also has one of these meta dictionary codified or an algorithm of these colloquialisms of all the ways that people have adverse events. Now, if it meets that criteria, it filters out again, and now we have a database. So it really comes down to this idea of algorithm design. It's not perfect, but we also recognize that it is the direction that we're headed. I'm reminded of the 2011 IOM, now the National Academy of Medicine report. There's a 2011 study that came out talking about the adoption of healthcare IT. It's a very large meta-analysis talking about every study that they had been able to come up with on barcode medication technologies, point of care testing at the bedside with the technologies, scanning, bedside scanning, intelligent infusion devices, electronic medical records, provider order entry. And they did a meta-analysis on all of these, asking the question, are we better off with health IT than we were without it? And the general conclusion was, we don't know, it's inconclusive. But we have to pursue this anyway because that's the reality. It's something whereby, it's something we have to adopt. And so that's kind of where we're headed. Well, here we go. I'm a bit of an excitable person. I got ahead of myself. This slide certainly is a review of what I was talking about. We have to create that potential design. We start at the bottom. We filter out all of these. Can we go through and parse out, pull down all the things with the identifiable reporter in person, filter by drug name, create a knowledge set of ADE terms, and finally, can we get a correlation to some of these terms as well? Just two final slides here I just kind of want to close up with is overall utilization. How can we do this? I've already talked again about this idea of the pipeline. How can we bring all those in? We want to make sure these queries can be grouped, sorted, trended over time, codified by severity, by geography. We need to make sure that this is incredibly useful and helpful to us. Collecting data for the sake of having it is not very helpful. This has to be able to formulate our decisions going forward, and it has to be useful. And that's certainly why I'm very grateful for the opportunity to speak about this today, is to be able to kind of close with this idea of the vision about measures and take some time to be able to get your feedback as well. Again, first of all, the overall vision, it's imperative that this research continue. We have just scratched the surface. I'm not comfortable saying that we've done any significant work that would fundamentally establish correlation or causality. What I think we've done is hopefully raise the interest level that more work should be done to realize that social media, there is a potential here that it is an incredibly viable tool to be able to add, again, supplement, not replace some of our surveillance tools that we've got to be able to look at some of these things. It also has to be a partnership. This can't be a unidirectional flow. This can't be something that is undertaken on behalf of regulators and proposed to manufacturers. I think manufacturers working in conjunction with regulators, academicians, measure developers, health plans, everyone working together to identify and get out ahead of this and be able to kind of formulate. The old notion is if you're not a part of it, if you're not working on legislation, you'll be legislated against. We need to work on this together to find out what can we do to understand this better and be able to come to a common understanding of how we use this tool to become mutually beneficial and ultimately prevent harm to the consumers that we all want to serve. Last and certainly not least, maybe potentially the most important, the questions that I want to pose to the group. Is there a place for this? Measure development. How do we use this? Certainly, one of the things, there's that problem of denominators. The idea is, can we ever accurately have a denominator? Is there ever an accurate way to be able to find out percentages or rates? Can we accurately describe it? Because the volume alone, again, we may have measures right now that talk about per patient encounter. Patient encounter may happen once a week, once a month, once a quarter. But when we talk about tweets, these are happening in the intervals of microseconds. And so with the idea of intervals can be very challenging as well at times. Just the sheer volume, billions and billions of tweets are sent out, and it becomes very challenging to find out what does that look like? How do we get a handle on what that volume looks like? Could there be a use, maybe potentially, as opposed to a measure? Perhaps this is something for a PQS, something that is a tool on a dashboard to reinforce the how or the why on behaviors. Is there a way to do a brief scan of social media behaviors based upon what we observe a measure through maybe a health plan or something? Is there a way that we might be able to build this in, again, as a supplement, as something that can help us fill in the gaps as opposed to serve as a primary measure? And again, the short answer is I'm looking for the answer. These are all just things I'd like to propose and things that I would love to have as a group discussion, and things that I think looking forward, you can see why I mentioned this is fairly preliminary, but one of the discussions, I'm very glad that you all shared some of your time with me on Thursday, and hopefully we'd like to hand this back over to Matt Pickering now so we can maybe enter the question and answer phase. But first, with that, I do want to go through real quick, and as I mentioned, and acknowledge some folks. I talked about Dr. Hertigan, Dr. Barrett Beach as well was fundamental in designing one of the original protocols. And my current pharmacy student, Carly Beal, has been absolutely fundamentally instrumental in getting a lot of this put together and bringing together many of the tweets, and also making sure that I use current vernacular as opposed to calling them anything other than tweets, singular or plural. So I certainly want to thank her. Matt?
Great. Thanks, Kyle. I appreciate it. Great work. Thanks for sharing what you all are doing over there at Purdue. Just to remind everyone that we do have some questions that have come in, but if you do have a question, please feel free to use the question box that's located up at the top right of your screen. You see a little Q&A with little thought bubbles there to type in your questions. So I guess, Kyle, to sort of start out here, with respect to measure development, you talked about how we could sort of look at social media for measure development. In the sort of algorithms and I guess the methods that you're using, you technically have a list of potential terms or words that you're searching for, and you're filtering based on that. And it sounds like that helps you do the confirmatory and validation type of work you've been doing with FAERS. With measure development, and if we think about patient-reported outcomes, is there a way to not have a set of terms or filters you're looking for to see if you can get something a little bit more organic out of the social media realm, if that question makes sense?
It does make sense. And so I would say the answer in short is yes. I think it comes with trade-offs. And so as with all things in social media, one of the things I had talked about in the problems, it comes down to a matter of scope and computing power and effort. And it's something that is one of our existing problems. And I will admit, confess it, I think it's a very solvable problem. But what happens is I think that on scope right now, one of our best tools to address it is the idea of the filter, the algorithm. The better we can parse through and find out exactly what we want, the more precise we are, again, the smaller the window. We can leave it quite wide open. We can find a way that people on social media have profiles. Some of them identify themselves by gender or by age. We can even just zoom in and say, I want all people of the demographic female from 24 to 39 that tweet about this drug name or said, I went to my primary care provider. Now, you're going to get tens of millions of tweets, and you're going to need to be able to kind of parse through a larger pile of data. It's a bigger haystack to find your needles in, but I think that certainly the day is coming, if it's not even already here. Again, I'm still looking for folks that have better answers. I think with more powerful tools, you're going to be able to get to some of those. So rather than having more criteria, having less criteria, but better ways to search that larger bolus of information. Right.
Because I was thinking along the lines of natural language processing and how a lot of organizations are using that type of technology to scan electronic health records, for example, in the clinical note and pull out information based on sentence structure. So you could identify a drug, but then an outcome that's important for a patient taking that medication, or maybe even that condition. If you're thinking about developing patient-reported outcome measures, right? Organically from patients communicating about issues or things that matter to them. I think you would want to be a little bit less restrictive to really identify what are the key concepts around that condition that matter to a patient or around that drug that matters to a patient. And that's kind of where I was thinking along the lines of natural language processing, or if you all are doing anything with that type of technology over there at Purdue.
Yes. So the short answer is we would love to do more. We've identified a partner that can do it. We've submitted a couple of grants as well. And so to the natural language processing, there are algorithms, there are folks out there that are doing this right now in marketing, actually. So with this, They can even, there are folks that can utilize Twitter, and they can go through and they can detect tonality. They can find out if a tweet is angry or happy or sad. And you can go through and you can find out how many people are speaking about drug X in a positive tone, a negative tone, an angry tone. And so, there are a lot of things you can do with the natural language processing, with tonality, with the phrasing or the language they use. So all of those things are wide open as opportunities. We haven't even really cracked the window wide enough even just to get our hand in yet with just some of these basic algorithms for identifying it. But the opportunities to go through and codify this in myriad different ways are wide open. But those are wonderful opportunities, and we are pursuing a number of those, yes.
That's great. That's great. So there's another question that came through, and this is about how social media can really be thought influencing. And we hear a lot of that. That's been happening in the media of late, with being something that it can even contribute to your own biases, et cetera, et cetera. Is there a way you can sort of filter that out? So something of a false type of post. If organizations, or you're talking about maybe ad agencies, right, know that social media is used to influence individuals, and the same thing with maybe types of medications or devices or what have you. There could be almost a flooding of sorts with those different types of posts that will be something to steer away from more of an adverse drug event or something of that nature. Is there a way to sort of filter those types of, I don't want to call them false posts, but maybe quote-unquote false posts?
I think we all know certainly there's a phrase floating around the mainstream media these days like that, but we'll avoid that. But no, to this extent, there are a couple of strategies out there. Again, nothing is perfect, but a couple that I'll address right now and make sure I've got time for more questions as well. There's a number of them. One, we can filter out. There's a lot of common strategies used right now on Twitter, whether it be the retweet or recycle information. You can go through and you can actually filter out anything that has been repackaged or resent a number of times. There's also the common notion that maybe there is an individual or a group that goes out and creates dummy accounts and creates spam tweets. So you can go through and you can filter out any account that has only ever processed or produced one tweet ever. And that tweet is, hashtag free Adderall, shoot me a private message, something like that. Or someone that's putting in, deliberately deceptive things. You can go through and you can kind of parse out some of the really malevolent things that are just really trying to cause harm. When it comes to some more of the biases, that's a little bit more difficult because, again, here we have perceptions of what some people may think is false. Others may actually find as true. There are folks, it was 10 years ago now, I was working in a hospital, and there was a patient that came in and actually had passed away. They believed at the time the big rage was Hawaiian noni juice. They thought that would cure their cancer. And so to them, that wasn't false. That was true. And so these are things that we want to capture and not consider them false or true, but we want to just try and quantify them by volume. And the final strategy as well is, honestly, sometimes it's sheer volume. The reality is, at the end of the day, we look at these, the volume of what are rather spurious tweets to genuine ones is in the single-digit percentages. And so we can start to, when it gets into the millions, start identifying those as less statistically significant. So those are just some basic tactics. Still a long way to go, though.
Yeah. Thanks for that. And there was another question about bots too. So it sounds like there's a strategy to address them, but there's still a long way to go there too.
Absolutely, yeah. We by no means have only good information. We're still wrestling with taking the good with the bad.
Right, and so are a lot of the larger big social media organizations as well, trying to figure out how to wrestle with that. The next question I have. And this may not be with respect to what you're doing, but maybe in some of the literature that you've been reading. But do you know of the reports that are received around adverse drug events within social media, have those also been able to influence providers in any way, and maybe even pharmacists in some way? Do you know if there's anything out there that social media has been leveraged to do that type of influencing around providers or maybe even pharmacists?
I've not seen primary literature or studies on the influence of, specifically when it comes to adverse events. There's certainly studies out there about the influence of direct-to-consumer marketing or some of the social media aspects on decision-making processes. But utilizing the same channel, we go through and we can find information that, if maybe not influencing decisions, it can be influencing conversations. Maybe the community pharmacist now can understand that when social media, when the volume of tweets it hits a fever, you can look at volume. You know, maybe 6 weeks ago, the number of people that were tweeting about influenza A or flu was, 100,000 a day. And now that we have all these announcements, it may be 10 million a day. When it spikes, it becomes part of the conversation. So now the community pharmacist may know that, hey, I'm going to get more than usual number of questions today from the patients that come to see me about, hey, is the flu shot working? Should I take my flu shot? Should I immunize my kids? There's going to be a lot more questions about, and when we talk, speaking to measures, about quality of care, about things that are happening. And so it can certainly shape conversations, but I have no evidence to demonstrate that it's shaping anything more than conversations at this point.
Great.
It doesn't mean that it's not, but it's, again, I'll stick to what I can and can't demonstrably identify.
Sure. So the next question I have, so with the limitations of the voluntary reporting for medication adverse events specifically and safety issues surrounding them, obviously there's been the push towards hospitals and health systems and individual physician practices and provider groups to move towards electronic medical record systems or EHR systems. There is a great opportunity there, and I mentioned earlier about pulling data out of the electronic note, the medical note itself that physicians or providers may write within those electronic medical platforms. Is there any knowledge or any potential intent to add that on to some of the work you're doing, pulling from the EHR as well as maybe social media, as the EHR may be a little bit more structured? Again, it's coming more from a provider than a patient, but there could be some information there. Do you know if any work has been done in that area?
Yes, we've done work now. Not specifically, we're just beginning with EHRs. We've worked with other intelligent devices that aggregate data. So we have about 150 hospitals around the country, and this is in conjunction with there's another group at Purdue called the Registry Center for Healthcare Engineering, RCHE or ARCHE for short, and we work with them on an intelligent infusion or a smart pump database. It's a comparative database. Hospitals share so every time you log or put a keystroke into a smart pump, it logs that data, patient name, age, infusion type, duration, length, hours, overrides, all of that. And we have a comparative database that compares all of that against guardrails, against all of that information. So we do. We've got comparative databases about what our devices and what our technology is telling us, but I still think that there is a long way to go before we start overlaying what I think the public is telling us about their interactions with those. So maybe those devices are home infusions or ways that people interact with things. I think that there is certainly a way to go before I would recommend making this part of a dashboard or a visual cue for someone. I think it, in concept, would be very neat, but until there is proof that it is making good clinical decisions as opposed to, misinformation or, really kind of bullying rather than providing good clinical information to clinicians, then I would certainly be hesitant to make any recommendation that this belongs anywhere other than just a research table right now.
Great. Well, Kyle, that seems like we have all the time we have for questions. So if you do have some of your questions not answered, please feel free to shoot PQA those questions, and we can try to get you connected with Kyle to get some of those answered as well. We want to thank everyone for being on the call as well, and also thank you, Kyle, for taking the time to speak about some of the great work that you've been doing. We really appreciated that. So just some final announcements. The PQA annual meeting, don't forget to register. The registration link is now open. It's May 16th through the 18th, and we'll be in Baltimore, Maryland. So please make sure to register, and we hope to see you there. Next, we want to just mention the Community Pharmacy Innovation and Quality Awards. This is a new award, so please click the link to find out more information, but nominate an individual or community pharmacy by February 2nd. So please take the time to click the link read through what this is all about and make sure to nominate an individual or pharmacy for this award. And finally, we have the PQA Healthcare Quality Innovation Challenge. This is a new opportunity for students to do a team-based competition, and those competition details will be found on our website here, but the competition will also be at our annual meeting this year. So please take the time to also pull this information up and learn more about that. That is sponsored by PQS, and I forgot to mention the Community Pharmacy Innovation Quality Awards is sponsored by the Community Pharmacy Foundation. So we're very appreciative of both of those sponsors. So thank you all very much for attending. We look forward to having you join us for future quality webinars, and please register for the annual meeting, and we hope to see you there. Kyle, again, thank you very, very much. Have a great rest of your week, everyone.